Ever wondered what happens when the brain fluid drainage system fails? Welcome to the world of hydrocephalus, where a silent buildup of CSF can speak loudly through clinical presentation. Hi, it is Dr. Ken, and this is neurology. So let's get started. In the previous video, we discussed about the brain ventricular system, and so be sure to watch the previous part before you watch this, because this is a clinical correlate of what we have discussed the other time. So today we are discussing about hydrocephalus, and the word hydrocephalus comes from two words: hydro, which means water, and cephalus, which means head. So hydrocephalus is literal accumulation of excess water within the brain, within the head, within the brain. So so we have the cerebrospinal fluid, and I think you remember the cerebrospinal fluid. And the cerebrospinal fluid, as from the name, it circulates between the cerebral, the brain, and the spinal cord. So the subarachnoid space within the within the brain and within the spinal cord, subarachnoid space. But we can have excessive accumulation of this fluid, and excessive accumulation of this fluid is what we call hydrocephalus. So we have like clinical presentation, the clinical symptoms of accumulation of the CSF within the ventricles or within the subarachnoid space is what we call hydrocephalus. So if you remember, we said an average adult like you and I can accommodate only 150 mils of CSF. Well, give or take, some might have 145, some might have 155, but an average of 150 should be fine. So you have an average, capacity of your, ability to accommodate this fluid. So when you have excess of what you could accommodate is what we call the hydrocephalus. You have an excess of the CSF, so excess of cerebrospinal fluid. So so now that you know that your brain is soggy, so accumulation of this fluid will lead into compression of the brain to the lateral sides, and first of all, the ventricles that accommodate this fluid will hypertrophy, will dilate. So we have the dilated ventricles, and the dilated ventricles what we call ventriculomegaly. So ventriculomegaly is dilatation of the ventricles, and because the ventricles are dilating, they are pushing the brain to the sides. They're pushing the brain to the sides because your brain is soggy, it is soft and moist and weight. Soft and weight. So ventriculomegaly is what we call is what we mean by enlargement of ventricles. So we have seen the problem that we have. It is excessive amount of CSF. So what are the possibilities that can bring to this excess amount of CSF fluid? Well, say what you say, but we have three possibilities. We have three mechanisms by which we can result into this excess CSF. Number one is by increased production of the CSF. So if we have increased production of the CSF, we can have hydrocephalus. We can have excessive amount of CSF. But I will tell you what, the increased production of the CSF is a rare cause of hydrocephalus. It is a rare cause of hydrocephalus. But we have decreased absorption of the CSF. So if you have a decreased absorption, obviously, so we have a build-up of CSF within the ventricles or within the subarachnoid space because you don't absorb. But what about obstruction? That's clear. So if you have obstruction, means, for example, we have obstruction somewhere here. We have accumulation of the CSF, proximal to the obstruction. So now that we know that hydrocephalus, it is ventriculomegaly. It is dilatation of the ventricles, and I tell you, the size of the head doesn't matter when it comes to hydrocephalus. Even though the cephalus means head, but the size of the head doesn't matter when defined hydrocephalus. What matters is the size of the ventricles. So most of the time, we want to confirm the diagnosis of hydrocephalus. We do imaging to see the size of the ventricles. We do the imaging to see the size of the. It could be an ultrasound, it could be a CT scan, but we want to confirm whether or not these ventricles are dilated. So we have something that we call the Evance score. The Evance score, we basically want to know how much percent of the volume of the cranium, the cranial cavity, is being accumulated, it's been contributed by the CSF. We want to know how much percent of the volume of the volume of the cranial cavity is being contributed by the CSF. So how is it calculated? Is by taking the width between the frontal horns of the lateral ventricles. So the frontal horns of the lateral ventricles, you divide by the biparietal diameter. So you take the distance between the frontal horns and you divide by the distance between the two parietal horns. So biparietal diameter. So what you find is what we call the Evance index. An average Evance index, the normal Evance index should be less than 0.3, which means maybe only 30% of the cranial cavity should be occupied by the CSF fluid. If we have more than 30%, 0.3, 0.3 can translate into 30%. So if you have more than that, means we have increased the size of the ventricles. Because if you increase here, means if you have excess of this, means we are increasing the size of the ventricles, and the size of the ventricles will increase with respect to the increase in CSF. So we have excess CSF that will lead into dilatation of the ventricles, and the dilatation of the ventricles will lead into to the higher value of Evance index, and so we have hydrocephalus. It might be clear, it might be maybe it doesn't make sense to you from this picture, but assume now you have ventricles like this. You have this is actually a actual CT scan from a patient. It was a baby she was around 9 months old or something. So you can see these are the frontal horns. So if you take the distance between this frontal horn of this one and this one, you find and you divide by the biparietal diameter, you find like it is almost maybe 0.9 or 0.8, which is 80% of the cranial cavity. So the 80% of the cranial cavity is actually accumulated by the fluid. So and you see that in this case is almost the whole brain is being replaced by the fluid, because you see, if you want to calculate the Evance index, you take the distance from here to here and then you divide by here to here. It's almost 90% or 90 something percent. So almost the whole brain is being replaced by the fluid, and this is what we call hydrocephalus. So it doesn't matter whether or not the size of the head has increased. That's not our concern. Our concern is the size of the ventricle, And you know that the brain is soggy, so the more the fluid accumulates, the more it pushes the brain to the lead skull. So to the lead skull. So we have seen three mechanisms, but what are the etiologies? What are the probable causes of these mechanisms? So what about increased production? What are the conditions that will lead into increased production of the CSF? Number one would be the choroid plexus papilloma. So we have something like a tumor that secretes the CSF at a greater extent. That will result into increased production, and the increased production will lead into excess accumulation, and excess accumulation will lead into dilatation of the ventricles, and that's hydrocephalus. And then we can have conditions that will result into reduced absorption of the CSF after it has been circulated. So conditions like inflammation. So we have inflammation around the subarachnoid space can result into impaired impaired absorption of the CSF. An example to it is meningitis, where when you have so this is why meningitis can result into hydrocephalus, because it impairs reabsorption of the CSF back to the venous drainage. But because the CSF is also reabsorbed to the venous system, when we have excess amount, when we have too much pressure within the venous system, so when we have too much pressure within the venous system, the fluid cannot get into venous system. Why? Because the flow of CSF is a backflow, and the backflow means it depends on the pressure gradient. So if we have too much pressure within the ventricles, within the venous system, it means this CSF cannot get into the venous system because of pressure gradient, pressure difference. That's clear. What about obstruction? Obstruction is the common cause of hydrocephalus. Most of the time we hear about hydrocephalus, the common cause would be obstruction, and obstruction can occur at any point along the flow of the CSF, along the flow of CSF, at any point. So whether it could be from the foramen of Monroe, it could be the cerebral aqueduct, it could be somewhere, wherever. So we can have a blockage at any point in time, and in absorption of in circulation of the CSF. So the tumors in posterior cranial fossa can also result into hydrocephalus, because it pushes, and when the tumor pushes this point, we have blocking this cerebral aqueduct of Sylvius. Does it make sense? All right. So let's classify the hydrocephalus. Of course, we have a lot of classification of hydrocephalus, but we talk about some of classification. And number one would be congenital versus acquired. Congenital hydrocephalus is the one that the baby is born with congenital hydrocephalus. And remember, one among the common causes of congenital hydrocephalus could be intrauterine infections. So when the baby is infected intrauterine, those what do we call them? Infections like toxoplasmosis can lead into congenital hydrocephalus. Torches, remember the torches. And then we can have tumors, you can have genetic mutations and stuff, but we won't dive into details about that. That's congenital, so the baby is born with it. And then we have acquired hydrocephalus, which means after the baby is being born. So it can range from few months to full adult. So at any point in time, someone can get hydrocephalus, and that would be acquired hydrocephalus. And then we have communicating and non-communicating hydrocephalus, and this we're going to emphasize it in details, but we have other classifications. So let's talk about the communicating versus non-communicating hydrocephalus. Well, let's start with non-communicating. As the name suggests, it is non-communicating. There is no communication between ventricular system. There is no communication between the two. So that's what we call obstructive hydrocephalus, because we have no communication between the ventricles. So obstruction can happen anywhere, as we have said, and the obstruction is the very common cause of hydrocephalus. Among all the three mechanisms that we have said, the commonest one is obstruction, and obstruction can happen at any point in time. So this will block the CSF flow, and so it will lead into dilatation of the ventricles, proximal to the obstruction. Well, so that's obstructing hydrocephalus. So we have millions of causes of obstructing hydrocephalus, and we won't dive into details. Now we're just classifying the hydrocephalus. We have communicating hydrocephalus. In communicating hydrocephalus, we don't have actual blockage. We don't have obstruction. There is no any obstruction in communicating hydrocephalus. So this could be, now you go back to the other mechanism, it could be due to increased production of the CSF, which is a rare cause. As I've told you, it is a rare cause of hydrocephalus, but so another possibility would be the decreased reabsorption. And under what condition do we have decreased reabsorption? As I've told you, maybe it could be to the pressure within the within the venous system, but infection, inflammation, subarachnoid hemorrhage. In subarachnoid hemorrhage, post-hemorrhagic change, example is subarachnoid hemorrhage. And subarachnoid hemorrhage means hemorrhage within the subarachnoid space. The hemorrhage within subarachnoid space will result in formation of clots, and then these clots will lodge into this arachnoid granulation, so and make it harder for CSF to be reabsorbed back into the venous system. And the subarachnoid space accounts for more than 33% of non-communicating hydrocephalus. So most of the time you say we have we have communicating hydrocephalus. 33% would be due to subarachnoid hemorrhage. And why is it the problem? Because it forms the clots, and these clots will lodge into this the clots will lodge into arachnoid granulations and make it hard for CSF to go into the venous system. But we have infection, as we have said, so post-inflammatory changes, something like meningitis, also it accounts for the causes of non-obstructing hydrocephalus. So that was number 2 classification, but we have some other classifications. For example, of course, we most of the time we have overlap between communicating and non-communicating hydrocephalus. So sometimes you can have non-communicating, it can change into we have communicating, can change non-communicating, the other way around. So we have other classes of hydrocephalus, and to mention few, we have normal pressure hydrocephalus. Just from the name, normal pressure, there is no increased intracranial pressure. There is no intracranial pressure. But we have hydrocephalus. Why? Because we have already said hydrocephalus, it is dilatation of the ventricles. So sometimes we have dilatation of the ventricles, but the pressure within the cranium, the intracranial pressure, remained constant. The intracranial pressure remained constant. It's not elevated, and that's what we call a normal pressure hydrocephalus. It is a topic of its own, and it's in a separate discussion. We have another hydrocephalus which is known as hydrocephalus ex vacuo. Hydrocephalus ex vacuo or ex vacuum. So this one is actually a little strange, because we don't have really dilatation of the ventricles. But we have a brain atrophy. So the brain atrophies. For example, when you get above 60 years of age, your brain starts to atrophize, and when it atrophies, now the brain atrophies, but the size of the ventricle remains the same. So when you go at any time to check the Evance index, we find the Evance index is elevated, but it's not really due to the size of the ventricles, but it was due to the shrinking of the brain, to the atrophy of the brain. And it will give the picture of the ventriculomegaly. So it will give the picture of the ventriculomegaly. So maybe these ventricles were of right size, but what has happened is the brain has atrophied, so the brain has decreased. So when you take the distance between here and here, you divide by parietal diameter. So the diameter between the parietal lobe of the brain hemispheres, you find it is elevated. But the size is actually the same. So that's what we call hydrocephalus ex vacuo. So let's discuss about the clinical picture. Of course, this also is not accompanied with the increase in intracranial pressure. There is no increase because we don't have really accumulation of the CSF. It is because the brain has atrophied, and then the ventricles they give the picture of dilated ventricle. So we don't have elevated intracranial pressure. So let's discuss about the clinical presentation of hydrocephalus. So the clinical picture of hydrocephalus is much influenced by the age, among other variables. Age matters the most, the onset, the onset, the rapidity of onset also matters, because in these babies whose sutures are not yet closed, so the cranial bones have not overlapped yet. So in these babies, they get the loom when it comes to the increased intracranial pressure, when it comes into the increased size of the ventricles. So we have the ventricular dilatation. The ventricles have dilated, and once the ventricles have dilated, they push the brain to the sides of the to the walls. And then when it pushes the brain, when the brain is pushed against the wall, it is it pushes the wall. So if the sutures are not closed yet, so if the bones are still widened or separated apart, there will occur an increase in the size of the head, because the sutures are not closed, so it gives the room to accommodate the new fluid, so the size of the head increases, and this is what gives a clinical picture of and this is what it gives a clinical picture of big head. So it gives a clinical picture of big head because it can be accommodated. Well, in adults, maybe not only adults, when the sutures are already closed, like in this case, there is no room to accommodate the new the increased size, the increased CSF fluid by dilating, by increasing the size of the head. So the size of the head does not increase after the sutures are closed. So what happens is the ventricle dilates, they push the brain is pushed against the wall of the skull, against the wall of the skull. So if I may ask you, what do you think, which one is dangerous between hydrocephalus in open sutures and hydrocephalus in closed sutures? Think for a second, for a few seconds. What is dangerous between the hydrocephalus in open sutures and hydrocephalus in closed sutures? Well, if you say this one, you are right. This one is more dangerous. Why? Because the brain is pushed. It is pushed, and then once it's pushed by the ventricles, it's also pushed against the wall. And now that your brain is soggy, so when it is pushed against the wall, and and it is prone to damage. So damage against the wall, also herniation. It can herniate. That's a separate discussion. So hydrocephalus when the sutures are already closed, like in adults, it is very dangerous. It is life-threatening, and it needs immediate intervention. So if you suspect an adult has got an acute hydrocephalus, there is if you suspect an adult has got an acute hydrocephalus, you need to intervene as soon as you discover. Why? Because it is a life-threatening. So what are the clinical pictures now of the hydrocephalus? So if the sutures are not closed yet, so if the fontanelles are opened, the sutures have not overlapped, so we have increased size of the head, as we have said, which is obvious because of the ventricles dilate. But we have widened sutures. The sutures face wide apart, so you see like this suture and this one, they become like wide apart. And we have the tense and the bulged fontanelle. So the fontanelle becomes tense and bulging out, and that it bulges out. But we have prominent neck veins, prominent scalp veins. So you see that veins become prominent because they are pushed. And we have the skin also. You see the skin, it becomes shiny and thin. It is thin and shiny and delicate. But we have low set ears. You see, we have low set ears. But look about the pupils. So the pupils will come closer to the lower eyelid. We expect the pupils to be centrally located, but the pupils and the iris. But in this case, you see the pupil, they approach the lower eyelid more. So it gives an impression. It gives an impression of the setting of the sun, and that and for this manner we call this the sunset eyes. So they have the sunset eyes, and probably the possible mechanism could be, impaired vertical gaze. So we have vertical gaze impaired in the brainstem. We'll have the arms can become stiff, and the legs are prone to contraction. And of course, when you do percussion of the head, you have this crack depot sound. So the crack depot sound, or the so-called Massive sign. But we have behavioral changes. Like they have high-pitched cry. They can have the delayed milestone, delayed mental retardation, not to mention. So these are the features when the fontanelle have not yet closed. So what if we have the closed fontanelle? What happens? We have a range of symptoms, from headache, neck pain, nausea, drowsiness, explosive vomiting, seizures, confusion. Almost it could be non-specific, so you have to learn the CNS examination, and you do the CNS investigations like CT scan and ultrasound. And what do you find in the case of hydrocephalus? We find the dilated ventricles. So what are the treatment options? The primary treatment is aimed to the primary pathology. So whether it was the increased production due to tumor, it should be addressed. Whether it was due to reabsorption, it should be addressed accordingly. But if we have a obstruction as well, the obstruction should be removed. The obstruction should be removed. But once all these are done, but still we have the hydrocephalus persist, we have to do shunting. So we have to diverge this CSF from the ventricular system to somewhere else, because within the system we have too much fluid than what we could accommodate. So we could accommodate only 150 mils, but now we have maybe 200 or 300 or so. So once we fail to address the cause, or we have addressed the cause, but still the hydrocephalus persists, we can do shunting. So we have a lot of shunts, and the very common one is ventricular. So this is what we call the ventricular shunting from ventricle to somewhere else. But the very common one is ventriculoperitoneal shunt. The ventriculoperitoneal shunt, which means the fluid is taken from the lateral ventricle and it is brought to the peritoneal cavity. So from the lateral ventricle to the peritoneal cavity is what we call ventriculoperitoneal shunt. This is a very common kind of shunt, and it is good because it is common and good because it gives room. Because when this baby has to be with this shunt to the rest of the life, rest of his or her life. So ventriculoperitoneal shunt, it is good because this peritoneal end can be made long, so that when the baby is growing, you don't need to go back to do another shunting. So you make it long, so when the baby is growing, it stretches and life goes on. So that's what is important, and it is most preferred because it gives room. We don't have to do much intervention when the baby is growing. Now, but at some points, we can have something like inflammation within peritoneum. We can have infectious peritonitis, inflammation of the peritoneum due to infectious cause, and we don't want to bring this infection to the brain. So when you put when the baby has got something, the intra-abdominal stuff, maybe he or she underwent surgery or has a peritonitis, we don't want to put the ventriculoperitoneal shunt this baby, because what we do, we will take this, we transfer this infection. The infection will ascend by the way of the shunt to the brain, and we call the serious damage you give. The brain is a sanctuary area. It is free from this microorganism and all the disease-causing agents, the infectious agents. So when you try to put the shunt in when you try to put the shunt in infected peritoneum, it may result into ascending infection to the brain. So in these cases, now we don't do shunts. We don't do the ventriculoperitoneal shunt. We can do other shunts like the ventricular arterial shunt. So the ventricular arterial shunt, the fluid is directed at the right atrium by the way of the shunt that goes through the jugular vein all the way to the superior vena cava to the right atrium. But we can also have ventriculoperitoneal shunt. The shunt can be, directed to the pleural space, and then we can have the lumboperitoneal shunt. So from the lumbar part of the spinal cord all the way to the peritoneum. But the most preferred one could be what? The ventriculoperitoneal shunt. But in case we don't want to do the ventriculoperitoneal shunt due to some reasons, abdominal surgery, for example, the abdominal surgeries or the peritonitis, we can prefer other forms, other modalities. But we also have other ways in case of obstruction. In case of obstruction, because you see the shunts, if you decide to do a shunt, you decide to do this shunt to the rest of the life of this baby, because you have not addressed the cause. So the hydrocephalus will be there forever. But if we could address something like obstruction, so assume we have hydrocephalus obstruction at the cerebral aqueduct of cerebus, we can address this obstruction by creating a hole along the wall, along the floor of the third ventricle, and then this fluid can get access into the subarachnoid space. So this is what we call endoscopic third ventriculostomy. So the third ventricle is being like inside, we make an incision at the third ventricle to allow this fluid to get access into the ventricular into the subarachnoid space. So this one will have, of course, it is a shunt, but this shunt has it is there within the brain. Like, you don't have these mechanical shunts like the tubes everywhere within your body. So that's very important. But sometimes there can also be like external ventricular drainage, like you have the tube like externally like pressed, you can see it, and then for some baby you can have ventricular tapping through the fontanelle, through the fontanelle. So this marks the end on our discussion on hydrocephalus, and if this video has helped you to grasp the concept about the hydrocephalus, please like and share, and of course subscribe and stay tuned for more cases to come, and see you next time.